Edema refers to the abnormal buildup of fluid in tissues. The fluid itself can either be a transudate or an exudate, which I'll explain in a bit. Our focus today will be on peripheral edema, which starts first in the legs as it is dependent. Dependent edema is one that is affected by gravity. Peripheral edema can extend from the legs to the sacrum, particularly in bedbound individuals. Pleural effusion and facial swelling may also occur on worsening. There are, of course, other types of edema depending on their location, including cerebral edema occurring due to trauma, tumor, or infection, periorbital edema due to trauma, infection, or allergies, and pulmonary edema due to left heart failure. Peripheral edema can be divided into two types, unilateral and bilateral. We'll enlist all the causes here first, then talk about them in detail. Unilateral edema is seen in deep venous thrombosis, lymphatic obstruction, cellulitis, and ruptured Baker's cyst. Bilateral edema is seen in heart failure, liver failure, renal failure, and inferior vena cava compression. From the causes of bilateral peripheral edema, let's talk about right heart failure. In a human being, deoxygenated blood from the whole body enters the right atrium via the superior and inferior vena cava. This blood is then pumped into the lungs for oxygenation via the pulmonary arteries. Due to right heart failure, the right side of the heart is unable to pump blood into the lungs. Blood in the right heart therefore has nowhere to go, building up pressure in the right ventricle, right atrium, and inferior vena cava. Eventually, blood in the legs cannot flow towards the heart and starts pooling in the legs. A rise in the jugular venous pressure is characteristic, as it indicates a higher pressure in the right atrium. Conversely, when the JVP is normal, it indicates a non-cardiogenic cause of edema. Patients with right heart failure can also present with an engorged face and pulsations in the neck. To diagnose, echocardiography is done to detect ventricular filling defects, and pro-BNP, a substance released in heart failure, is measured in serum. Bilateral peripheral edema is also seen in liver failure. Liver normally functions to produce albumin. Albumin contributes to colloid osmotic pressure in the vessels, allowing the vessels to retain fluid. In liver failure, albumin levels drop. Decrease in albumin means decreased colloid osmotic pressure, so fluid diffuses out of capillaries, leaving behind larger molecules such as LDH and proteins that are too large to cross the membrane. This fluid, known as transudate, causes edema in liver failure. Other signs of chronic liver disease include spider nevi that are swollen vessels just under the skin, leukonachia, which is the whitening of nail beds, gynecomastia, the abnormal enlargement of breasts, and portal hypertension. Diagnosis of liver disease or failure is based on a combination of liver function tests that become raised and prothrombin time, which is also raised due to the decreased production of vitamin K by the liver needed for synthesis of some of the clotting factors. Bilateral peripheral edema seen with renal failure can be due to nephrotic syndrome or nephritic syndrome. In nephrotic syndrome, proteinuria occurs, so body loses albumin. This causes colloid osmotic pressure to drop, resulting in transudate edema. In nephritic syndrome, oliguria occurs, so body retains fluid. This causes hydrostatic pressure to increase, allowing fluid to leak out of vessels, resulting in transudate edema. Other signs in nephritic syndrome include hypertension and a raised JVP, both due to volume overload. Symptoms of renal failure include oliguria, shortness of breath, fatigue, nausea, and loss of appetite. To diagnose renal failure or injury, renal function tests and albumin levels are measured in serum, both of which are raised. Proteins in urine are detected by urine dipstick and can be measured in a 24-hour urine sample. The last cause of bilateral peripheral edema is inferior vena cava compression. Compression of the inferior vena cava can also cause blood to accumulate in the legs, resulting in bilateral leg edema. What's unique about inferior vena cava compression is that edema does not extend above the legs and is not influenced by gravity either, meaning a bed-bound patient with inferior vena cava compression won't develop sacral edema. This condition is seen in malignancy or morbidly obese individuals. Diagnosis is made by a color Doppler ultrasound abdomen to detect the disruption of blood flow and CT abdomen. Now let's go through causes of unilateral peripheral edema. First, we have deep venous thrombosis, where the edema has a slow onset. The formation of a thrombus occurs most commonly in the great saphenous vein and obstructs the passage of blood from legs to heart, causing edema. The thrombus can also dislodge, travel to, and block pulmonary arteries, leading to pulmonary embolism. Diagnosis is based on Wells criteria, which involves checking D-dimer levels in serum and performing a color Doppler ultrasound of the affected leg according to degree of suspicion. Next, we have lymphatic obstruction, which occurs due to metastasis or spread of cancer into draining lymph nodes, for example in metastatic melanoma. The edema in this case is non-pitting, which means applying pressure to it does not form an indentation. Why this happens is because the lymphatic fluid consists of proteins, and fibrous tissue proliferation hardens the area over time. Another cause of unilateral peripheral edema is cellulitis, a bacterial skin infection which triggers histamine and cytokine release, which in turn cause vasodilation and increased capillary permeability. Features of cellulitis include signs of inflammation, which are redness, heat, swelling, pain, and loss of function, as well as fever. The two most common bacteria involved are Staphylococcus aureus and Streptococcus pneumoniae, and cellulitis usually affects the lower legs. Any infection can be diagnosed on the basis of a raised white cell count, raised CRP, which is an inflammatory marker, and a blood culture that tells us which bacteria are involved. A ruptured Baker's cyst can also lead to unilateral peripheral edema. A Baker's cyst is a fluid-filled swelling which forms in the popliteal fossa just behind the knee joint. It can form as a complication of arthritis of the knee or a knee injury such as anterior cruciate ligament tear. Symptoms include sudden onset knee pain and calf swelling. For diagnostic purposes, Baker's cyst can be visualized with an ultrasound of the knee. Lastly, immobility can lead to unilateral edema, such as in the case of a fractured leg, or bilateral edema seen in bed-bound patients. While edema is a symptom rather than a disease, it still needs to be treated. Mild cases can be treated by keeping the legs elevated, even just by placing pillows underneath. Chronic cases can be kept under control with the help of compression stockings to aid blood flow. As always, treat the underlying cause whenever necessary. Loop diuretics are given intravenously or orally to reduce the edema by draining fluid from the body, keeping in mind side effects of long-term use such as dehydration, hypokalemia, and hypernatremia. Loop diuretics can also be combined with thiazide diuretics for added effect. In some conditions, potassium-sparing diuretics such as spironolactone are used, such as for ascites and liver cirrhosis. The liver cirrhosis leads to raised aldosterone, which causes potassium excretion in the urine. The resulting hypokalemia would therefore only be worsened with diuretic use unless potassium-sparing diuretics are used. With that, we've covered edema, the causes of edema, their symptoms and diagnosis, and the treatment of edema. I'll be making similar videos on palpitations and heart murmurs next, so see you then on sqadia.com.